Good afternoon. I'd like to welcome our audience today to the 22nd Annual John Collins Harvey Lecture, sponsored by the Pellegrino Center for Clinical Bioethics at Georgetown University. My name is Father Miles Sheehan. I'm director of the Pellegrino Center for Clinical Bioethics, professor of medicine, and the David Lawler Chair of Catholic Healthcare Ethics here at Georgetown University Medical Center. Today, we are honored to host Dr. Siva Subramanian in a conversation with Dr. Kevin Donovan about Dr. Siva's extraordinary career in neonatology, bioethics, and interreligious dialogue and understanding. Dr. Siva is Emeritus Professor of Pediatrics and Obstetrics and Gynecology at Georgetown, Emeritus Chief of Neonatal Perinatal Medicine, likewise at Georgetown, a Fellow of the American Academy of Pediatrics, a member of the American Pediatric Society, a recipient of the Interfaith Bridge Builder Award in 2007 from the Interfaith Conference, a recipient of the Interfaith Bridge Builder Award in 2019 from the Interfaith Conference, as well as receiving in December of 2022 a Lifetime Achievement Award from President Joseph Biden. In our conversation, more of Dr. Siva's remarkable achievements will be discussed. I'm grateful to Dr. Kevin Donovan for leading our conversation this afternoon. Dr. Donovan is also an Emeritus Professor of Pediatrics at Georgetown, as well as the Emeritus Director of the Pellegrino Center for Clinical Bioethics. Kevin is my immediate predecessor as director, as well as a good friend. Before we begin our conversation between Dr. Subramanian and Dr. Donovan, please allow me to share with you just a bit about Dr. John Harvey. Dr. Harvey was a distinguished clinician, researcher, and medical educator. A graduate of Yale and the Johns Hopkins Medical School, Dr. Harvey was a faculty member at Hopkins before moving to Georgetown in 1973. Dr. Harvey was a leader in establishing the specialty of geriatric medicine. Dr. Harvey was a man of deep Catholic faith and in 1989 acquired a PhD in moral theology from St. Mary's Seminary and University in Baltimore. A close friend of Dr. Edmund Pellegrino, Dr. Harvey worked as faculty with Georgetown Center for Clinical Bioethics until his death in 2017. Having had the privilege to meet Dr. Harvey, I can testify to his warmth, humor, and erudition. I am certain that Dr. Harvey would be delighted as we honor Dr. Siva today. So now, Dr. Donovan, would you like to begin?
You bet. Thank you so much, Dr. Sheehan, Father Sheehan. And Siva, I think this is just a really wonderful Harvey lecture, more of a Harvey dialogue, in honor of our mutual friend, John Collins Harvey. As you can tell, I'm honoring him by wearing his signature bow tie today as well. Those who knew John knew you never saw him without a bow tie. But what I think we're going to be able to talk about today are the aspects of your remarkable career in medicine and in bioethics. And even in neonatology, you were practically there at the beginning for both of these important fields. Let's start talking first about your Georgetown journey. You came to Georgetown as a neonatologist and then developed it from there. Why don't you tell us how all this began?
Thanks, Kevin. It is very nice to have this conversation. So, we thought about in terms of making a presentation and all those things, but this will be more engaging. So thank you for consenting to do the dialogue. And I also want to thank, Miles for inviting me to be the, speaker for today, on our friends, the lectureship created on a friend's name, John Collins Harvey. And I thought, I will say a couple of things about that, and then before starting on the journey part. Number one is, in terms of Dr. Harvey and I were in Baltimore before coming here in 1973, Dr. Harvey came. I followed in his footsteps, and came in 74. So our relationship started, a year after he came and the year I came in, a little bit more intensively after 76 when I became a faculty. And, as Miles talked about, and, he's the most delightful gentleman, in addition to being an erudite physician. And we have had some great interactions. And, he was the first hospital ethics committee chairman. Then he handed it over to me. And so there was a lot of interactions between John Collins Harvey during the years that he was here. And it's really my honor, to even step up to talk a little bit about my association with ethics in this journey. The second, I just also want to acknowledge and thank Dr. Pellegrino, which we'll talk a little bit more about, later on. And there is one thing that I did. I preceded Dr. Pellegrino to Georgetown, and when he came in '82, I think as a John Carroll professor, and then in '83 he became the director of KIE. And we have had some, great interactions, and we will talk a little bit more about that as well as we, moving on. I hope this conversation helps people to have an understanding of where, and how ethics started, and what was the Georgetown's role in it, and how did I get involved in this? It's a fascinating story. And so I wanted to acknowledge those things right up front, and then talk a little bit about in terms of my journey, because since we talked about Dr. Pellegrino, I also came from Brooklyn, which is where he came from.
Yes, I thought I detected a Brooklyn accent.
Exactly. And so in 1971, I arrived in New York and acquired the Brooklyn accent, and from there I, came to University of Maryland and in Baltimore when Dr. Collins Harvey was at Hopkins, and so I finished my residency, and my chairman at the time was one of your friend, Dr. Marvin Kornblatt, was in glucose metabolism. And so I had an opportunity to do either one or the other as a chief resident at the University of Maryland, or take the fellowship at Georgetown. Contrary to Dr. Kornblatt's expectations, I decided to choose and come to the fellowship to Georgetown. And so that's my brief story, in terms of how I ended up at Georgetown as a fellow in neonatology.
Well, you had even told me you'd changed your mind even before that, because that's how you ended up as a pediatrician before you became a neonatologist. And I thought it was just because when you experienced American medicine, you recognized that the pediatricians tended to be the most amiable of the physicians available.
That is true. I know.
I've been told that, as well as the most intelligent and the best looking. Isn't that what you told me?
Yeah, it is true. But what Kevin is referring to is I actually started with thinking in terms of doing pediatric surgery. But then when I had the rotation in the NICU, all the babies that were there and all that, it just really caught my attention, and decided that's what I'm going to do. And that's the reason I finished the residency. And I didn't want to take the chief residency because I just want to go on to do about neonatology.
Which was Georgetown's gain, I think.
Yeah.
So you arrived at Georgetown, and we should say the rest is history, but go ahead and fill in some of those gaps. You stayed at Georgetown. You didn't just do a fellowship here.
Yeah, I think it is, of course, I love Washington, D.C. with all its, varied population, restaurants and all those things, and the museums, and free too, and it was good. And Georgetown was a wonderful atmosphere. I did have some little apprehension when I came as a fellow, because this was a Jesuit institution. How will I, merge with this, backstage, and I mean, in terms of the background and all those things. And so the fellowship will help consolidate, in terms of that. That's this great institution, looks at very broadly, and at the same time, what happened was when I came in, one of the reasons I came in as well is in terms of ethics. The Kennedy Institute of Ethics was started in 1972 by, we all know the visionary Andre Hellegers, who also was the first director for about 8 years, 71 to 79. And so this was something that I got interested, in fellowship itself, but even before, even in the internship. And so that's a challenge that I wanted to see, how it can be handled. And Georgetown has always led, in terms of the ethics. And so I felt that this would be something that, I can learn, and in terms of applying, because I deal with life and death, as a NICU faculty, and as well as, the pain and suffering, the grief that the parents go through and all that. And so that's how, the Kennedy Institute of Ethics played a role, in terms of for me to come in.
And at the time that this ethics began to grow and take root at Georgetown, you were growing into not just a faculty role, but you also became the chief of neonatology, did you not?
Yes, and this is, the chair of neonatology at the time I joined the fellowship was Dr. David Abramson, who was a brilliant man. And but for some reason, I hope it's not because I joined, in 1976, he decided to step down and, retire. Not retire, actually, when did something else. And and then Dr. Mary Kay Davitt, followed. She was a wonderful chair, for about 5 years. And she then decided, for family reasons, to move in 1981 to Maine, where she became the chief. And then, raising her two kids needed some attention. And so I became one of the youngest chiefs in neonatology in 1981. And then I stayed stuck, in that position, which I loved in terms of what it is, for 40 plus years till I retired in 2022.
Well, here you are, chief of neonatology at a young age, dealing, as you say, with life and death decisions on an almost daily basis, certainly with important ethical involvement and ethical overtones, and a new field growing, new field of bioethics growing at Georgetown. The KIE is formed. Andre Hellegers brings in other stars, whom we will mention as we go along. And then shortly after that, Edmund D. Pellegrino comes to Georgetown as well, as soon as director, and from the same KIE that is now being directed by our friend and colleague, Dan Salmacy. So how did you start interacting with this the star group down campus
Yes.
from you?
Yeah, it's very good, because in terms of 1976, since even though it started a little bit in 74, but after faculty, I got more interested and involved in KAE. I started attending the meetings, at KAE, and then met some of the stalwarts, as you mentioned, Dr. McCullough, Dr. Reich, Dr. Eli Walters, Dr. Weech. I mean, these are all pretty much a household names in ethics, and
Right.
throughout the United States. And so I felt this may be the right time to bring them in into the hospital. These are philosophers, and said, let us bring them in to the, into the reality about which they are talking, researching, and publishing. And said we brought them in. And Larry McCullough was one of my friends who readily agreed, to set foot in the hospital and started, having conversations. And then that led to having, this is, I'm talking about 76, 77, in that time, 77, 78, in that time frame. Started monthly conferences, in the NICU conference rooms.
So at this time, they were focused on the NICU and on pediatrics, not for the general hospital yet.
No, not at all. Not at all. It is simply, this. And there are certain things happened in United States, at the same time. Number one, I should acknowledge, Hastings Center for Biomedical Ethics started in 1969-70, just barely starting in New York. And so these two institutions are really the ones that led the way in terms of influencing the course of ethics in the United States and abroad, as well. And so we started this, and we used to have Dr. Nina Scribano. She was running a spina bifida clinic in the Department of Pediatrics. And this is from, 72, 73. And she used to have a care committee, that used to look at some tough cases, in terms of ODs. She brought in others as well, and other specialists. And so that was there in the background. I knew about that because, Nina is part of a department, so we were aware of that. And spina bifida babies that we have eventually go to her clinic. And so by this time, we realized, there are things that are happening in the United States. Started with 1976 Quinlan case, where there's a whole question of the ethics of withdrawal of not alone life support, but also food, started talking about because their parents asked for that in the court, and then finally court agreed. And this, which is a national, news and came about. But still, it didn't go anywhere, in terms of hospitals creating committees or groups or anything like that. But then in 1981, 82, the baby doe case from Bloomington, Indiana, that was the national approval, in terms of a Down syndrome baby, the parents asking for, discontinuation. And that was a major issue that went on. And the federal government at that time started coming in.
It is worth noting, I think, that in this new era of bioethics, because there's always been attention to medical ethics in the profession, but in the time frame that you are mentioning, a whole new focus on the issues and development and discussion of these issues took place. Two baby doe cases, at least, if you don't even count the earlier one at Johns Hopkins, which really caught the attention of a number of pediatricians like yourself, who became very involved in the field of bioethics, as well as the practice of medicine. And interestingly enough, the baby doe cases tended to be Down syndrome cases, where the information being transmitted to the parents sometimes wasn't always accurate about what could be done or what the prognosis would be. So one of the outcomes of that, of course, was not just this federal involvement, which really was very difficult. I think your NICU was probably like mine, where they were putting up signs in the NICU, if you think this child is care is being neglected, here's a hotline, call, 1-800-GET-FEDS or something almost impossible. Yeah. That happily did not persist, but the interest in bioethics did. And in fact, you started developing some of the things that were recommended. Like they had said, let's have infant prognosis committees or infant ethics committees or something like that. What'd you do at Georgetown?
Yeah, I mean, in terms, because of all this uproar, Dr. Teal was a pediatrician, practicing pediatrician. She was involved, she was interested in these issues, and she, uh, you know, suggested maybe creating infant ethics committees, maybe the right direction to go. And so I felt that makes sense. And we already had a de facto group functioning, that with the spina bifida babies. And so we said, okay, we will, instead of calling it as an infant care committees, we will call it as a infant ethics committees. And so I decided that with my colleagues and then Dr. Shibano and with Larry McCullough and others, started, the infant ethics committees at Georgetown in the early 80s.
And you did more than just individual patient consultations, although you did that as well, because I understand this was about the time that you developed the pediatric ethics conferences, doing retrospective case reviews and discussions and such. Isn't that right?
Right. There are two components to it. One is starting from late 70s to 80s. I started inviting the professors in the KIE and the Department of Philosophy at Georgetown University, and I started having instead of occasional contacts, monthly um, meetings where we can present a case, sometimes present topical discussions, and actually started as a topical discussion, and subsequently we were able to present cases and stuff like that as well. Retrospective cases is what we did first, and we were still wetting our feet in terms of what this is all about, and then subsequently started doing prospective cases and all that. And we didn't know that we are actually starting the ethics consultants at that time. Subsequently they were called that.
Right.
Yeah.
So you had these pediatric ethics rounds going on, which continued to go on, educational rounds, but also case discussions. And you and Edmund Pellegrino
Yes.
and Gabby Hauser,
Yes.
started these conferences, and they went on for years and
Yeah.
years. I know that there were at least over 250 of these conferences held over the past years.
Yes.
But didn't the hospital start to realize that there were cases that were not just in the pediatric venue, and that there were even doctors who weren't pediatricians but were still ethical?
Yes.
So I think that the tail may have wagged the dog in this case, because the hospital then developed an ethics committee as well.
Yeah.
And
I
who
think
headed
just,
that ethics committee?
yeah, just before, say exactly. Even before we started, I have to give the credit to Gabby Hauser for starting it in 1990, started the Pediatric Ethics Committee, and he and I coordinated many of the meetings with Dr. Pellegrino. But even before that, in the middle of 1980s, 85 or so, as you correctly said, the hospital recognized that there are other areas of medicine, there are some ethical issues that can come, you know, and that also needs to be addressed. And also, um, so they started the hospital ethics committee, and who else but our dear friend Dr. John Collins Harvey, started the uh, first chair, and he was phenomenal. He also brought, the cases were brought to this committee, hospital ethics committee, from all over the hospital. Wherever there are issues that are, it's question of whether this is the right or what, and either by the nurses or the doctors or social workers or anybody. And, at that time, it didn't start with the patients, but subsequently we did. But, we started that, probably one of the earliest in the country, started as hospital ethics committee addressing all the issues. We did, because of the infant ethics committees were there before, we continued to function as infant ethics committees and discuss this. But the hospital ethics committee could include the babies as well as adults as well, and it was phenomenal. And then in 1990, by the time Dr. Pellegrino, who came in 83 as a director of this, is now transitioned to as the director of clinical bioethics at the Georgetown University Medical Center. And so immediately Gabby saw the opportunity, and he and I talked, and then he established this pediatric ethics committee. As you said, did so many of them educationally, as well as looking at cases of all subspecialties, of outpatient and inpatient, everything.
And one of the remarkable things I think that developed at Georgetown was this melding of the expertise of the PhDs, the philosophers, and of the clinicians, to really enhance and develop the field of clinical bioethics. And at that time, there was really no such field. And there was certainly no educational programs or academic programs to learn that. So you were working alongside Ed Pellegrino and John Collins Harvey, and the three of you kind of characterized what it meant to be a clinical bioethicist. And I think that your formal ethics training back in the day was pretty much the same as Ed Pellegrino's, and until he went on to get an academic degree, the same as John Collins Harvey, which means you had no formal degree, no formal education. Neither you nor Pellegrino nor Aristotle had a degree in ethics. And yet, we're integral in developing this field. And you got some attention with that too. As I remember, you put on a pretty big meeting.
Yes.
On an international symposium.
Yes.
For perinatal and neonatal ethics.
Right. Because I was interested from the 70s in ethics, involved with the Kennedy Institute, and the three of us clinicians, and those with PhDs, and I started really coming together, integrating and discussing. I thought it is good to invite an international conference on neonatal perinatal ethics, and I had invited many people from here. Actually, Mildred Stallman was one of them. I had invited her from Tennessee, and internationally, Hito Kimura, from Japan, Martin Sass from Germany, and also from from England and from Italy and other countries. And of course, Dr. Pellegrino was the main reason why I dared to start a conference, in terms of it. So he was the initial speaker and laid the groundwork, and Warren Reich, Veach, and Larry McCullough. And in fact, Larry and I were the co-coordinators of that international meeting. And rightfully, a clinician and a philosopher, joining together and doing it. And what happened was, subsequent to that, I started putting those proceedings together, asking those people who presented to actually submit an article, and seminars in perinatology, accepted, that proceedings, and publish a full monograph on perinatal neonatal ethics. And Dr. Queenan, who was the chairman of the OB, and Larry McCullough and myself edited that monograph at this point. Yes.
Well, and I remember that monograph. In fact, I remember the article that Pellegrino wrote for it on ethical decision making, which is still a classic. We use it with our students still. And you yourself got a little recognition, I think. Newsweek did a kind of a cover story on intensive care for babies. And as I recall, you were the centerfold.
No. What it is, this, by the time it was late 80s, And, we had, obviously a lot of intensive care babies in terms of being in the, as a tertiary care unit. And through that, one of the Newsweek, reporters and started looking at this, and they were just fascinated. And in fact, the cover of Newsweek on May 16th, 1989. Not that I remember correctly. you know,
Well, it's probably the only time you've been a centerfold.
no. So it was a cover where one of our babies in an incubator and a nurse was, shown, and then it was almost a 10-page, center page articles. And I was a little photograph there and somewhere there, but it was about the babies, about the preemies, and this was in 1989. And so in the cover, they said 5 years ago the miracles started at 2 pounds. Now they begin at 1 pound. This was on the cover of Newsweek.
Wow.
You know,
Yeah.
yeah, and
Well, and that does kind of bring us to the topic of the landmark and challenging cases that you've dealt with in your own career, medically challenging, but also ethically challenging.
yeah,
Now you've mentioned some of the landmark cases like Karen Quinlan, and that's the
John,
first time we had a really good, serious discussion about withholding and withdrawing at a national level, I would say,
right,
and the various baby doe cases and what they led to and what they triggered in terms of the attention to bioethics in the hospitals across the country. But in your unit at Georgetown, you mentioned the spina bifida cases, which were medically and ethically challenging, but you had a whole series of other issues as well that perhaps you, in the time remaining, you can tell us something about them.
yeah, and it is really something remarkable. There are so many. I mean, we don't have enough time, to be able to talk about all of those different, cases that we have had. And but this is at least as issues that came about. For example, in the 70s, we had to deal with scarcity of resources. It's not just a hospital issue; it's an ethical issue because physicians ended up selecting which patient, adult or baby or a child, to put on ventilator, and that's a challenging situation. And and those resource restrictions, even adults existed with the dialysis machines. The same kind of issue. We thought that we don't have much resources issues these days, but COVID came and taught us.
Right.
Same thing: ventilator scarcity, oxygen scarcity, and all those things. So that's one of the major issues. Uh,
And certainly with the number of transplants done at Georgetown Hospital, scarcity of resources includes the scarcity of organs for
Organs,
transplantation. Not as big in the NICU, but certainly in pediatrics and adult medicine for sure.
yes.
And like you said, the vents, ECMO, COVID issues,
Hmm.
these all reflect back to the principle of justice, which is one of the
Yeah,
four principles in the Georgetown mantra, for which Georgetown is so well known.
yeah,
Uh, and I think that you had some other challenging cases, some classics like Jehovah's Witness
yeah.
babies.
These are some of the things that happen early. Because, for example, in the mid 80s, um, there was one place in Ann Arbor, Michigan. They were doing the extracorporeal membrane oxygenation. And I felt there was so many of these respiratory failure cases needed some more intense intervention. So we all went there and got trained and came back. And after getting ourselves trained in the lab, my colleague Dr. Marty Kessler and myself started the ECMO at Georgetown. And in ECMO, you need tons of blood. And so the blood transfusion becomes major issue. And prior to that, there was simple transfusion to premature babies was also issues. And one set of parents who were the parents of the premature baby that needed transfusion were Jehovah's Witness. And they appropriately, said, no, we would not give permission to the transfusion. And so we have, I think Georgetown had established a case in way back in 1962, 63 with an adult Jehovah's Witness in terms of transfusion. At that time, that sophistication of what it is there now, that adult can refuse. So there, that went in terms of the hospital can transfuse that adult. And so then this, our hospital contention with legals was that it can be done. And so that was the precedent that allowed us to be able to do ECMOs in those babies. And the parents, when we got the court order and told them that we did, after telling them they're giving them time to, come with appropriate their case, and so we mentioned it. And
I think Dr. Siva, that most of your listeners are aware that Jehovah's Witness parents who are faithful Jehovah's Witnesses may care deeply about the welfare of their child, but it is thought of as a damning action to receive blood for themselves or for their children, and for themselves, they would typically rather die than do what they think is immoral. So it becomes a huge ethical question,
right.
as well as the medical question that you were describing as well. And of course, the child can't speak for themselves, and the parents do speak for the child. But you found this was an instance where you needed to override the parents' right to make decisions for their child in the child's best interest.
Yeah, very, very rarely, we do that, because we acknowledge parents' prerogative to make decisions for their babies, unless they can for some other reason, but most of them are, absolutely. And we deeply respect the religion that they are in and their point of view. We are absolutely, we feel the compassion as well as the respect for that. But in this situation, who is the patient? The patient for the neonatology team is the baby. And so we just need to make sure what is in the best interest of the baby is what we have to discuss. And, obviously, these are all the ethical principles that we try to apply. And since most of the time, a substituted judgment or the patient's, ability to give consent is fine. But in this case, the best case interest of the baby requires that we need to get that, But we do that very rarely. In fact, very, very rarely.
Right. And in this case, you had told me the outcome was excellent. The child survived.
Yes.
And went home with the parents.
Yes.
And even though the parents had been overridden, you said that they were happy to have their healthy baby home with them.
Correct, because they
I think it's also worth noting at Georgetown, they've taken this issue so seriously that there is a whole blood program for those like Jehovah's Witnesses, who don't want to receive blood transfusions.
Yes.
And that is taken very seriously, and they have alternatives in place and readily available, which is all also developed from this type of issue that you had to deal with in the early days.
Correct. That was, I think, very progressive of Georgetown in terms of to acknowledge that those kind of situations. And we all know now, even adolescents as well as adults, and can refuse transfusion, and we respect that.
Sure.
There's a whole program, that is there.
Did you have any other challenges? Did you ever have anything like multiple births?
Is that right? Did we have one? So this was something that was in the year 2001. We got a call from an obstetrician, a practicing obstetrician, that that she has a mom. She has taken care of the mom in her pregnancy, now reaching 20 weeks. And remember, this is 2001, because this is after all the baby door regulations, BIPA, and all those regulations, and babies born alive regulations, and all those kind of things. And so she called, because if the baby comes, born, babies, come alive. And so she said, I said, what? So she said, yeah, we got multiple pregnancies. Okay, we handled multiple pregnancies. In fact,
Sure.
one of our obstetrician was a kind of an expert in that, Joe Collier. He was an expert in multiples, and we have done 2, 3, 4s and all as well, babies. And so Georgetown was known for that, to be able to handle that. And many of the high-risk pregnancies, multiples used to be transferred here. And so this was going to be, and then the OB chairman, and we looking at each other, because mom said, it is 7 babies.
7.
7 babies.
Lucky
Right
7.
now, 7 fetuses, not babies actually, yet, 7 fetuses. And so that immediately, was an issue. So we had ethics committee meetings, and we really looked at all the options, saying, yes, we should take that mother and see the best that we can do, after explaining to that mother and the father all the risks, and to the mother's life, as well as in terms of the baby's chance of survival. So after doing all of those things, at 23 weeks she was admitted, and we were expecting delivery at any moment, from 23 weeks, 24 weeks on. And but she held on in bed rest till 27 weeks. And then at 27 weeks, the labor started, and taken to the C-section. And there was a team of 40 people in the in the cesarean section room, which, by the way, by design, we had built the NICU and the OB next to each other. So the C-section room was next to our NICU, and that was done, way back in the 90s. And so the babies, and then we had about 50 people on our side, with the teams assigned to each one of those seven babies. And the obstetricians, to their credit, Dr. Winkle was the chairman at the time, delivered the babies in 3 minutes, and then we brought them, lined it up, and the teams took care of them. And so that raised major questions of uncontrolled IVFs, without counting in terms of
Right.
multiples and stuff. So I went on national TV and international TV and raised this question in terms of that we as a professional group should self-regulate in terms of how we handle IVFs, as well as in terms of, if not, I said, since we had some experience, the government will step in, with regulations and all that. But the professional society of the MFM, did address those things and made some great recommendations.
And in this case, as I understand it, you had pretty great outcomes despite the
Not
multiple
for all of them.
births.
Not for all of them. Subsequently, we knew that there are 5 male and 2 females.
Ooh.
As we know, the females are always stronger.
I've been told that.
Yes.
At home.
And so those 2 baby girls did fine, went home. Of the baby boys, 2 of them didn't make it out of the NICU, and 1 went to PICU, didn't make it. It's all severe. And then we found out later on, when the boys are getting problem, that the parents who are international parents have had some situation of a condition with baby boys affected more, GI inclusion disease, and so they are really had two of them had transplants.
Wow. So you're hitting the whole range of ethical challenges in a case like that. And I think that you've had some problems in other babies with congenital deformities and genetic anomalies. Have those come up not just in the NICU, but also in your ethics committee and conferences?
Yeah. The thing is that came from, the baby doe in terms of Down syndrome, who have, 21 chromosome being triple. But then we had babies with 18 and 13, chromosome issues, and then there was because most of them historically lived only for a short time. Many of them didn't even get out of the NICU. But then with support and all that, many of them live longer now. But at that time, it was very challenging.
It was very challenging, and I think that we have to be honest as those in the field of pediatrics that one of the reasons we're seeing better outcomes, not just with trisomy 21s who can do very well in their development, but even with the 18s and 13s, the trisomy 18 moms came to the National Ethics Committee meeting and said, you're not keeping these kids alive, and you're saying that they have a very poor life expectancy. But that becomes a self-fulfilling prophecy.
Yes.
And now that people are agreeing to do the life-saving interventions for some of these kids, we're seeing that they can actually live much longer than the textbooks had taught us.
Exactly. Now we know Down syndrome babies live up to 50s, 60s.
Right.
And, at least this. But let me bring one other thing when you said about this self-fulfilling prophecy. And I started this neonatology in 1970s. WHO had the definition for pre-viable infants at 1,000 grams and 28 weeks of gestation. That was it. That's how
Right.
everybody followed it. But we started showing already in the 70s, we can save 26, 27 weeks and some 25 weeks as well, down to 500 grams in the 70s. So that definition for us didn't hold anymore. And because in the past, they did not give the support to those babies less than 28 and 1,000 grams, unless they lived by themselves, and they died. So that was a self-fulfilling prophecy. So when we started doing it, and now if you ask how small is too small that we have to go, is really a challenging thing, because we had continued to drop to like 24, 25 seemed to be a border where we couldn't cross. But then there are some parents at 23 weeks who were infertile. This was the only chance for them, and they wanted to doctor, give it a try. Whatever happens, fine. And so we tried it. Sure enough, higher and higher percentage of this baby started living, and then now we go to 22 weeks, and the 22 weeks we're talking 50% survival. Not alone survival, half of them are normal.
Incredible.
Yes,
Incredible.
and the remaining have mild to moderate to severe, no question. And so this is a self-fulfilling prophecy, something that in medicine we need to make sure we always should challenge.
And I think it's hugely important that people understand the progress that has been made in answering that question, how small is too small? But the progress has been made by physicians such as yourself in conjunction with the parents participating in that decision. Yes. To at least give some of these super small, very low birth weight babies a chance, not putting them through things that they cannot tolerate, not persisting when it doesn't work. But look what has happened. It's just remarkable. And you've been at the forefront of all of that. You and I were talking not long ago about American president who had a premature baby. His wife did. And yes. And that unfortunately that baby was just too small.
Yeah.
And do you remember what gestational age?
I don't know how many people will remember this. When President Kennedy in the 60s was there, his wife Jackie had uh, difficult pregnancy issues, and after difficulties, she had two live born who are doing fine. And then when actually the president was in the White House, she delivered a baby. Wait, at 34 weeks.
34 weeks.
Yes, she was taken to a military hospital and in Massachusetts, and baby delivered, and the baby was having difficulty in breathing, was taken to Boston Children's Hospital, where the baby lived a total of 39 hours and 14 minutes and died of respiratory distress syndrome at 34 weeks.
And this was like, I think, 1963.
63.
Right about just before you entered the
Yeah.
field of neonatology. Look where we've
Basically.
come, simply
Yeah.
because people kept asking that question, how small
Yes.
is too small?
Yeah. And
It's
so
remarkable.
now we are talking 22 weeks, 23 weeks, and that's
Right. If you got a 34 weeker in your NICU now, the alarm bells would not be going off.
oh, they will go to intermediate care nursery.
So tell me something. You've seen all these developments with the concomitant medical and ethical issues going forward. But even though you have stepped down as the director of the NICU, you're still involved in the ethical issues yourself.
Yes.
Where do you think we're going in the foreseeable future? What sort of bioethical issues are going to be challenging to the physicians and the population?
Yeah. Before that itself, and including, we can look at other population as well. One of the things that worried Dr. Pellegrino is the physicians who are taking care of the patients. We always call it as a calling that we are got drawn into this profession, and but over the years they have been assigned a role of healthcare providers, and there is only one time I have seen Dr. Pellegrino upset is when somebody mentions this, and because he felt that this person is not a job, this person is not doing somebody's bidding, either insurance company or hospital systems. It is something that out of their conviction of what they want to do to take care of the most vulnerable at the most difficult time, and with integrity, compassion, and knowledge. They bring the knowledge, in terms of that. So that is one thing that I am worried. I mean, at this age, I can really worry about that because, it is something that we need to relook at that, aspect. But having mentioned that, my pet peeve, and is how small is too small is going to still exist, but maybe extending into potentially an artificial womb.
Mhm.
There have been studies, I mean, the research is done up in Philadelphia and up, further up in terms of having sheep in artificial wombs outside the, womb. And it's not going to be too far to be able to grow a baby, human baby, in there. What are the
That will
ethical
be a game
implications?
changer.
Yes. What are the ethical implications, of this? And then now there is a polygenic embryo screening. And this is at the early stage of that to see what is the tendency for that embryo to develop into, and making decisions on in terms of that, and where is it going. It's just short of enhancements, to look at that, but it is in terms of, but also there are, in single gene situations like Tay-Sachs, it really makes a difference, to prevent the pain and suffering and all those of the babies, and this, to find a fetal diagnosis of Tay-Sachs. But there are others also will come into that. But this business of polygenic embryo screening, I think this is something that we'll have to pay attention to in the future. Not that I'm here to give answers, but it is here something that we have to look at. And then artificial intelligence. Now, it's going to impact, the technology as well as in terms of all of this, in terms of taking care of patients of any age and every age that you can think of. And of course, new technologies and the resources scarcity is also going to be coming in. And there are religious issues, particularly like in the United States, where it is every religion that just can be represented, and they have different perspective. The medical good is not the only good to bear upon the patient. There is a patient's good that the patient has to express or the surrogate has to express in terms of what is good. And so the increasingly looking at the shared decision making is the right way to go. But I think we have to be careful about, respecting, as we talked about Jehovah's Witness, respecting them and how we made changes here, creating a blood program, and so that is going to be coming up, about, treatment, not treatment, withdrawal, withholding, ventilators, other technologies, and so on and so forth. These are all coming up very rapidly in the near future.
And you have had a challenging and exciting career in neonatology. It is perhaps almost comforting to know that your interest in bioethics will be sustained by these challenges in the coming years, and you can stay involved in that as well. Dr. Siva, I think this has been a fascinating as well as an entertaining review of both your life and the field of bioethics, particularly in neonatology. We have just a few minutes left, I think, if you would be willing to take some questions that have been submitted from the audience. There may be some people who will need to sign off at this point, but I'm happy to go on as long as you're available.
Sure. Yeah.
I'll just try one for you here and see how you do. Can you expand on how you're helping families understand that reducing morbidity is really a more important goal in medicine than just reducing mortality? How can you help people grasp what long-term suffering inflicts on the patients, the families, and society?
This is a crucial question. I mean, this is something that maybe earlier on in the 70s, we were focused on improving the mortality. And then subsequently, as we learned, by the way, we have a follow-up clinic as well. So we follow these babies so that we get to know what happened to these babies. We also have a NICU reunion. So that when they come back, even the babies who have had problems and who did well. So we get to get informed. And there are now parent groups that put meetings, and we attend them and to make sure learn from them, in terms of what it is. And it's something that we also have to be very careful about not we put our biases, in terms of the morbidities into the parents, but explain to them what are all that we know. Give them the data, not alone of the mortality, also in terms of the data of the morbidities, in terms of follow-up, what happens and what. In fact, one of my friend, Dr. Saroj Saigal from Toronto, has published a very long-term follow-up, like 40 years, and published in talking to the parents and the children who have grown up now with the disabilities as to how they are. And that's an article worthwhile reading. And we get to be challenged by those children who live, how well they value their life, in terms of what they have done. And also we need to realize in terms of what severe morbidity is caused. But over the years, we are now talking about in a NICU like ours, like 98% or 96 to 98% of the babies get admitted to the NICU survive, and over 90% of them are normal. So
that is, I think, such an important point to make. That's one of the wonderful things about your NICU reunions. Those who work in a hospital, especially those in training, but also the nurses sometimes, get to see the terrible situations, the heartbreaking situations, and the suffering. But when that goes away, but the child survives and thrives, we often won't have an opportunity to follow them long enough to see that happen. So having these reunions, as you do, where you see these darling children coming in with their families, and most of them doing so well, and hearing from those who still have some residual problems saying, yes, but this is a good life I'm living. I think that is really a crucial and extremely important aspect of understanding the risks and benefits of what's being done. And as long as we're talking about NICU care, we shouldn't let this close without pointing out that NICU care itself, although expensive, is more cost effective and has more lives saved and patient years extended than adult ICU care or
Yes.
cardiac care.
Yes.
So, what you've been doing for these kids has not only been getting better, but has always been extremely important. Here's another question. It says it's relevant for patients of all ages. Contrary to common bioethical or legal argument about withholding being not a treatment as withdrawing is because it does not affect the patient's body, unilateral DNR, especially without due process in ordinary situations, as distinct from, say, COVID scenarios, does cause the end of life in the body of a patient and does cause interaction with the body. Does it not? Do you want to?
It is a good question. There are two components here. In terms of unilateral DNR, I'm not sure whether that is something that for adults, since the person mentioned about all ages,
Right.
shouldn't be happening unless the person is incapacitated. Then somebody else, surrogate should speak for the patient, and
Certainly.
permission should be obtained for in terms of any of the DNR issues. If nothing else, if there is a situation, you can go to the court to be able to get that. And again, so the due process should be followed. In terms of any DNR, leave alone unilateral DNR, and the person addressed about the COVID situation also, because there are so many things that are happening that are extraordinarily different. And the point that the questionnaire makes, yes, if the person dies, it is the end of the story, and so it is something that we have to be aware of before we make that decision. And
granted that this is a very complicated issue. I think that you have touched on all the important points, but you could write a chapter on it.
Easily.
Oh no, I did write a chapter on it in the new Pellegrino Compendia.
Yes.
So I'd suggest our questioner buy that book.
Yeah.
Read the chapter and get back to us.
Yes.
Here's perhaps a good question that we can close with if we run out of time. A great discussion. Thank you. From the angle of global newborn health, do you look into possible variations in bioethics and relevant recommendations in relation to low and middle income countries that face different types of challenges, and all solutions for high income countries may not necessarily apply to them? I think that is something right in your area of expertise.
Absolutely. That's a fantastic question, because I referred to WHO definition of in the 70s, why it said less than 28 weeks and less than 1,000 grams are pre-viable, because large data in the world showed that was it. That is, the majority of the places, they will not live. They cannot be sustained. And so WHO wanted to maintain an international standard in terms of what it is. Not that is something that is not achievable, in every places, mainly in the low and middle income countries where the resources are not there, in terms of the expertise may not be there. And so it has to be looked within it. I mentioned about we published seminars in perinatology in the late 80s. In the last chapter, I write with Larry McCullough, you know, relating to neonates, but it'll apply to anybody. How, you can look at making decisions on the fetus and the neonate and the parent. In that, I include culture, religion, countries, resources. So if you see the model, that's the last model that I have put in, and it reflects all of it. So what this questionnaire asking, in terms of it should not be the same as in the high income. I agree with that completely. The ethical issues are the same, but in terms of where it will end up will depend upon as well as what is available. You just cannot do anything more than what resources allow or what expertise allows, in terms of it. But it's not the same thing that copied and put in every place. They have to address their issues within the ethical framework, in terms of what we talk about. We didn't have time to go into the ethical frameworks and all that, but within that, yes.
Well, thank you. I think that's a good answer, and I think that's not a bad place to conclude our Harvey session today. As you know, the Harvey speakers have been, world renowned. They have been, cardinals. They've been world renowned bioethicists, as well as physicians and clinicians. And Dr. Siva, I think you follow in that tradition very well. Thank you for a very entertaining and thoughtful Harvey discussion.
Thank you very much. I hope Dr. Harvey approves of this.
I am sure he would. I am absolutely sure he would.
Thank you for everybody for this.
And thank you to our audience for those good questions. And this concludes our program.